I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
Thank you all for joining us today. My name is Rebecca Kiesling, and I am the Director of Programs at the Benjamin Rush Institute. I am very excited to be able to have this conversation today. It's a pretty big day in our little world of healthcare and of free market medicine. If you haven't heard, CMS has issued a pretty historic final rule on price transparency, which helps to ensure that every American knows what they're paying for before they actually have a service. This is a really big rule because price transparency is going to require insurance companies to disclose their predetermined rates first. You can ask those at any time. There are people that have been doing this for some time, and then there's people that have been doing this for a long time. And we get to talk to one of the originators of all of that today. I am, again, Rebecca Kiesling of the Benjamin Rush Institute, and this is part of our live event series. We started this series in response to the COVID-19 pandemic when medical schools across the country closed down at the very beginning of the pandemic. We usually have live events across the country and in our medical schools around the world. And we wanted to keep that education of free market healthcare going. Our main purpose is to make sure that the doctor-patient relationship is the primary focus. And with our events on campuses in over 40 in the United States and across the world, and constantly growing, we're able to do that. Now that events are virtual, we have this series and we have virtual events going on now that medical schools are in session. We are very excited about this series. We've had a wonderful response to it. And so we thank you. If you have been to some of our series before, thank you for coming back. You can always capture and watch the ones that we've had. We do record them. We put them up on our YouTube channel, so you can go visit that. And we will be as I said, we record this and it will be up on our YouTube channel later. I'm very excited to talk to Dr. Keith Smith today. He is a pioneer. He is someone that our students constantly ask to speak with because not only does he have a name that is so well respected in what we do, but he is someone that is so willing to talk to our students about what he does and where he's going. He launched the first website displaying all-inclusive pricing for various surgical procedures in 2009. So that ruling that came down today, he's been doing that for a long time. And it started getting national attention because who does that? What is now the Oklahoma Surgery Center is owned and operated by around 40 of the top physicians and surgeons in central Oklahoma. Canadians, uninsured Americans, they take advantage of this low and transparent pricing that's available. what you're seeing at the surgical center is the availability of this free market outpatient surgery center, where Dr. Keith Smith is an anesthesiologist. He's the medical director, the CEO, and the managing partner, while he also maintains an active private practice. The Surgery Center of Oklahoma is one of the few medical facilities in America that openly posts the prices of their surgeries on its website. You can go right now. You can look it up. You can find out what the entire price of your surgery, whatever that surgery is going to be. Try doing that with anything else. He has spoken about this on national television. He's spoken about this at conferences. He speaks like he's going to be speaking to us today about this and why this is so important. To encourage the widespread adoption of his proven methods, he co-founded the Free Market Medical Association, which we are so happy to be partners with, which helps to revolutionize the medical care through treatment of cost transparency. Where we are today with price transparency wouldn't have been possible without Dr. Keith Smith and his partners starting what they did in Oklahoma, talking about it like he has throughout the country. I'm thankful to him. The rest of the country should be thankful to him. And I know our students are so appreciative of how open and honest he has been with them. You're not here to talk to me. You're here to listen to Dr. Keith Smith. Please ask your questions, and I'm going to turn it over to him now.
Thanks for having me. I think there's no more important audience for me to talk to at times than medical students, because one of these days I want to have a doctor that works for me and understands the basics of economics and why we have to talk about that. Is probably as much as you're told through your training that you should never talk about these sort of issues, certainly about money or financing with patients. I'm here hopefully to dispel you primarily of that. Whenever I talk to medical students, I start and end with the same admonition. And I'm going to start. Don't ever go to work for a hospital. And I'll end with that in case you forget everything else I've said. I hope you remember that, but I'll mention that again at the end of this talk. The title of this talk, Economic Fallacies in the Delivery of Medicine or Medical Service, is inspired, to be frank, from writings of Frédéric Bastiat, the French philosopher and economist, who wrote an entire book on economic fallacies. He wrote another one. It was actually called Economic Sophisms. And he wrote another one called Economic Harmonies. And if you're not familiar with Frédéric Bastiat, Bastiat, it's very eye-opening stuff written by fellows mid-19th century who died a very, very early death, I believe of tuberculosis. But the stories about Bastiat were at the end of his life as a legislator in the French legislature. I guess it was a parliament. Even though his voice was reduced to a whisper, you could hear a pin drop because even his foes, they understood they were dealing with a genius and someone whose logic was just very, very disciplined. So Frédéric Bastiat talked about economic sophisms or economic fallacies, and I'll talk a little bit about those today. I'm also going to blend it with some kind of economic concepts or things that are really not economics, but some policy, perhaps failures of government, even though that's redundant to say government is policy failure. There's some things to consider that have had economic consequences that are not necessarily fallacies. So to start with, story. Early in our partnership, in 1997, when the Surgery Center of Oklahoma started, we had 10 surgeons that were partners, and one of them was angry with me because he wanted to be assigned a higher percentage of the revenue that we actually distributed to the owners at the end of the month. And his reasoning was this, that he was trying so hard, that his effort was so much more intense than all the other partners, that he wanted to be rewarded for his efforts. I told him that the distributions that we gave to the partners were based on results, not on effort. You didn't get any E's for effort when you went through school, just like me. And we did not reward partners based on effort. His thinking is downstream of what I think economists would refer to as the labor theory of value, where he was trying to make the case, not in these words, but that his value to the partnership could somehow be derived from how hard he tried. He wanted to be reimbursed for his participation trophy, basically. This labor theory of value is a disaster. And this is a concept I would encourage you to read about. It is the foundation for Karl Marx's socialism. So the labor theory of value basically states that something is worth what people have put into it with labor and materials. This was all stood on its head by an Austrian named Karl Menger, who wrote a book called Principles of Economics that's actually very easy to read and was written for the layman. It's good summertime reading. It's something you could easily read in 5 or 7 days but you're a medical student, so you could read it in one night. The Principles of Economics made the case for the subjective theory of value, and here's why that's important. The subjective theory of value basically says something is worth what someone will pay for it, and that's way oversimplified, but we all think of that as true. But that's where it came from. It came from this guy, Karl Menger. He also pointed out that a Maserati or a Bentley or a Lamborghini may represent one value to a Wall Street executive. It may represent a completely different value to a monk. So value is very subjective. It's actually completely subjective, and it resides completely in the realm of the buyer, of the customer, of the patient. So our patients actually determine our value, and the value that we deliver is actually completely determined by the subjective determination of that value from the buyer. There is no determination of value that is inflicted on the marketplace by the sellers. That is very important and something for you to keep in mind as physicians when you're dealing with patients. So the labor theory of value, if anybody ever roots for that or tells you that's a good idea, you now know better, and you know where to go to read about the subjective theory of value, which comes from the Austrian School of Economics. And that's the brand of economics that allows all of us potentially to be armchair economists, where we can actually look at certain events and human actions through a lens that makes events around us, I believe, more clear. Some other fallacies, I would argue, those of you that think that long-term, your reimbursement, your pay that you receive for what you're going to do from a hospital is going to be better than in private practice, I would encourage you to rethink that. I would argue that is a fallacy. Hospitals are going to pay any of you that make the mistake of going to work for them probably a nice fat salary when you first get out. all of which will be renegotiated into the toilet as the years go by. You will realize at first that, I'm going to get this check every month, kind of regardless of what I do because of guarantees that are built in. Then later, excuse me, they'll inflict the teeth of the RVU, relative value unit guide, on you, and you won't be producing enough RVUs. And then the goalposts will change, and you have to produce even more RVUs to maintain the same salary. And before you realize it, you will be a slave. So I would encourage you to recognize the big hospital payday for you when you graduate actually as a fallacy, as a true bait and switch. Where do prices come from? This is a fallacy, and I think most physicians, even in ones in private practice, don't completely understand this. When we put our prices online in whatever it was 11 years ago, in 2009, when we put these prices online, they were already prices that I had written down because we had been quoting prices over the phone since 1997 when we opened. I would call a surgeon and ask them, how much do you want for this or that procedure? And the surgeons never knew. They have learned since then to place a price on the service they are going to deliver using time, really, and some expertise modifier, but usually it's just how much time is this going to take. The surgeons did not realize that the prices that had been imposed on them, and that all began in the early 1990s when insurance companies, and this all started with the disaster of Medicare's resource-based relative value scale. The smart folks at Harvard decided they could attach a price to everything that we do. And they inflicted this pricing on physicians. And since half of the American medical system is socialized under Medicare and Medicaid, TRICARE, VA, Indian Health Service, that's about half of the American health system. It's already socialized medicine. They had a pretty big hammer to hit people with. And when they said, we're going to pay you $78 to do this anesthetic for a total knee, I had a choice. I could take, and that's an actual number, I could take their $78 or I could just quit participating in their scheme. This is not real pricing. Whenever prices are inflicted on us, that's not real pricing. And it's always wrong. It always creates shortages or surpluses. There were many things that were overpriced when this pricing was inflicted, and those services became abundant. And there were many things to which a very low price was attached, and those services became very scarce. These are the kind of concepts that, as medical students, you should be aware and not dwell on them terribly, but really understand them, because then when someone is trying to inflict pricing on you, you realize this is not real and it has consequences. True prices emerge from a competitive marketplace based on the actions of individuals. And when we put our prices online, we didn't realize that when everyone saw our pricing, we actually created a marketplace. There was now something to compare to, and the buyer would use our pricing actually and inflict our pricing on one of the price gouging hospitals who suddenly found themselves in a competitive market. A market for surgical services was definitely created when the first competitor of mine posted their prices. And then there was, I would argue, a true marketplace. But just keep in mind where prices come from, kind of what they are. This is just touching on pricing, but hopefully it's giving you something to sink your teeth into, to look into further. Whenever you're talking about free markets in medical service delivery, the naysayers, and even sometimes the well-intentioned naysayers, will ask the following question: what about the poor? I would encourage you to read about the straw man logical fallacy. Most people who ask this question, what about the poor, are you definitely using the straw man sort of methodology to take the wind out of your sails when you're advocating for free markets. What about the poor is a loaded question, and it assumes aggregates. So when people ask this question, they're not talking about any individual poor person that they happen to know that has a specific problem or condition that would benefit from a remedy. They're talking about the poor in aggregate. My partner, Steve Lantier, one time when asked, what about the poor, responded and said, at current prices, we're all poor. So, the idea that, we have to create a situation under the banner of the free market that right now takes care of everyone who cannot pay a single dime is equivalent to not being nice to your neighbor because you think world peace is out of reach. This is a straw man argument, and anybody that takes an argument, I'd say, and asks it in an aggregate form, they need to be reduced to the individual. So I would ask someone back who asks an aggregate question, like what about the poor, an individual question, what person are you talking about? What individual do you have in mind? If you really want to get nasty, you could say, well, I know what my intentions toward an individual would be. What are yours? How are you going to step in and help? Because many times people asking this question have no intention of being part of the solution. We could go on and on with the what about the poor, but my point here is to be aware of a question that comes at you framed through the lens of the aggregate. It's the welfare of the many is preferable and takes precedence over the welfare of the individual. And we all know where that leads. It leads to socialism and communism and fascism and death. And so radical individualism is a very positive thing. And people who ask you aggregate questions should be made to refer to individuals. Let's talk a little bit about the fallacy where everyone believes that insurance companies want to spend the least money possible on care that their supposed beneficiaries receive. That's actually not true. Insurance companies want to spend a lot of money, and they want to pay their pals at the hospitals a ton of money. Some of you may have heard this before, but hospitals will throw a $100,000 bill at an insurance company with whom they have a contract, and the insurance company is happy to receive a $100,000 bill from a hospital for something I might do at my surgery center for $8,000. The reason the hospital is happy to receive this bill is that they then say, well, even though we know you're going to pay us $20,000, we're going to claim that the $80,000 you didn't pay us for our $100,000 bill is money that we lost. Now, if the hospital is receiving $20,000 for a procedure I would do at my facility for $8,000, I think everyone listening would argue that they are making money. If they're not making money, they should be making money. But the hospital is happy to receive a $20,000 payment instead of the $100,000 because they then claim they lost $80,000. And believe me, the hospitals are making so much money, they need that $80,000 loss to maintain the fiction of their not-for-profit status. Understand, not-for-profit just means don't pay tax. And in order for these big hospitals to not pay tax, they have to show that they didn't make any money. And the way they show they didn't make any money is they claim that they rendered all of this care for which they were not compensated. The insurance companies are happy to receive also these $100,000 bills from the hospital because they claim that having discounted that bill down to $20,000, that they have actually saved their client $80,000. Then they masquerade as the savior to the employer group, for instance, who they work with. And they say, the power of our insurance company and our PPO network has brought you this discount. And now, per the terms of our agreement, you should pay us a commission based on the discount that we've achieved. Keep in mind, all of these payments are prearranged. And that's why this CMS final ruling that mandates that these agreements between hospitals and their insurance pals be revealed and these pre-negotiated rates be available for everyone to see. This scam of, we have discounted this and we've saved you all this money and now pay us a commission for our hard work. All of that is unmasked. The brokerage houses that sell these insurance plans to employer groups are actually paid commissions to the extent that the employer group's experience was disastrous. So if there are a lot of complications, there are a lot of $100,000 bills or $1 million NICU babies, that is really good for the brokerage house that sells Blue, United, Cigna, Aetna, because they actually receive a payment many times that's calculated as a percentage of claims made. I tell people no insurance companies want to work with the Surgery Center of Oklahoma, and the reason is our prices are out there for everyone to see. And so, discounting these claims and charging a commission is what the Austrian economists would call an opportunity foregone. And that's a great concept, an opportunity foregone. And when you think about that and you realize that as economizing individuals, we have multiple choices in front of us. And when we make choices, we exhibit our preferences, and the choices that we avoid or don't make are opportunities foregone. The insurance companies do not work with Surgery Center of Oklahoma because they can actually make more money dealing with someone who charges them more. So I would argue that this is an economic fallacy for people who think that insurance companies make more money when they actually pay less for the claims. That sounds insane, but I hope that was understandable. Another fallacy that is inside of the Unaffordable Care Act is called the medical loss ratio. This is part of Obamacare that requires that no more than 30% of an insurance company's revenue can be spent on administrative internal sort of costs or expenses. This was written by the insurance companies because they knew, and they loved this 30% limitation, because they knew their smaller competitors could not comply with it. This is one of those regulations that was actually written by the industry and inflicted on themselves because they knew when the dust settled, there would only be 4 or 5 of them left. That's exactly what happened. So while the mom and pop insurance company might need more than 30% for operational expenses, a huge insurance company that's many, many tens of billions of dollars, huge companies, 30% to them is a lot of money, and they can easily afford their operational expenses. The other thing about the 30% medical loss ratio that limited insurance companies' ability to keep money in-house. That sounds great. Masquerading as, the good guys. The other thing is the only way then the insurance companies can really make money is to jack up their revenue. So, whatever next year's revenue is, if it's larger, then that 30% number is larger, but the other number is much, much larger. I've explained not-for-profit means don't pay tax. Hope you understand now the insurance companies and the hospitals are not at each other's throats. Their interests are very much aligned. Another reason insurance companies do not work with my facility is that there are volume guarantees. So many times you will be in a situation during your career where someone will ask you, how much would you like to be paid for an office visit? How much would you like to be paid for a consultation, a pacemaker, a tonsillectomy? And you will be inclined to respond in the following way. You will ask, well, how many patients are we talking about? What kind of volume are we talking about? This is part of the problem with the medical system in the United States, where hospitals have basically forged these alliances and relationships with insurance companies where they've told the insurance companies, if you reach a certain volume, then next year's contract will be the same or even more favorable to you. In other words, the hospital will charge the same or less the following year rather than jacking up their rates year to year as they do. So these volume discounts are part of what keeps insurance companies from working with my facility, because if a large number of patients comes to Surgery Center of Oklahoma, that large number of patients for any of the procedures we perform do not go to one of the hospitals that has in place one of these volume guarantees. One of the tenets of the Free Market Medical Association is everyone's charged the same price. That's why that's there. It's to guard against and to really keep on everyone's radar the possible downside and consequences of these volume guarantees. So that I would argue that the volume guarantees is an economic wonderful thing for a medical practice. Ultimately, that is a fallacy. I would also argue that even the folks that run Medicare, they don't even care what medical care costs. They exhibit every day a desire to work preferentially with hospitals rather than high quality independent surgery centers. They overpay hospitals. They overpay physicians who work for hospitals in comparison to those in private practice. And then hospitals use that revenue to offer graduating medical students, like many of you will be soon, unheard of salaries that are way beyond what the market should support. That doesn't last. Your salaries will drop precipitously very soon. And then, as I've said earlier, you'll feel like a slave. But even Medicare doesn't care. I don't care what they say in Washington, D.C. They really don't care that Medicare is going bankrupt, that it's a Ponzi scheme. They don't care what it costs because they could be paying far less. The prices on my website are half what Medicare pays the hospitals across town for me. The prices on my website are less than what Medicaid pays the hospitals across town for me. So it's quite interesting when someone wants me to shoulder the burden of what about the poor when these hospitals, after all, are so grossly overpaid and don't pay tax. I want to cover whenever you are labeled, some tinfoil hat advocate of free markets and medical care delivery, someone will bring up a couple of fallacies. One is, but what if you're in the emergency room? When I was on the John Stossel show the first time, he made this point, and I thought it was very compelling, that if an emergency room financially takes advantage of a patient who is completely vulnerable, the market is still at work. The market works not just right now in real time, but the market works over time and in the future. So the reputation of a hospital that might take advantage of a vulnerable patient would be damaged. With any luck, it would be damaged irreparably. So over time, not particularly not maybe for an individual patient, but over time, the reputational disparagement that would occur for an abusive price gouger like that would take its toll, and they would be run out of the marketplace. So the idea that the free market does not discipline or bring accountability to an otherwise price gouger in a situation like that, I do not believe is valid. Keep in mind, too, people that bring this up are assuming, think about this, they're assuming the patient will be taken advantage of. So everybody knows that these big hospital systems, with the rarest exceptions, are vicious price gougers. That is the default, and understand that is inherent in their question. The other thing that will come up that I think is also a fallacy is the wide disparity in information that the patient has versus the physician who is treating them. This informational disparity was key to the argument made by the socialist economist Kenneth Arrow, who won a Nobel Prize for making the case that markets do not apply to this industry. It is absolutely not true. I mean, think about it. Think about the situation we have now, having followed a very controlled, heavy-handed central planning socialist policy in the United States with regard to our healthcare system. The information disparity on, do I need a tonsillectomy or not? Do I need a valve replacement or not? There is so much more information that is available to patients than there's ever been. But I would argue this was not true even when Kenneth Arrow wrote this article that gained him such notoriety, because we as physicians are guides. And I don't know when I take my car in that it really is the carburetor versus something else. So there's information disparity everywhere. What we rely on is the market to weed out the unscrupulous players. And we also many times will rely on a guide. And in medical care, physicians will rely on patients will rely on their physician to be their ombudsman, their advocate, their guide. Patients will rely on us to not send them to a butcher of a surgeon. They will rely on us to not send them to an unethical, knife-happy surgeon who just operates on everyone. And unfortunately, some of those people are out there. The reason those people are out there is the market is not at work. So what we see in the medical system that is all the stuff we hate is, I would argue, a situation where the market has not been allowed to work. When the market is at work, people go out of business who should go out of business, the butchers and the unethical players who unfortunately are out there. And so I'm going to come back to where we started, and I guess we have time for questions. But where I started then is, don't go to work for a hospital. Because if you go to work for a hospital, that dilemma is inevitable. You will be forced to make a choice. You'll be forced to decide, do I do what is right for this patient, or I send them to the butcher surgeon that is also employed by my employer? Do I dare send this patient outside of my hospital system, outside of the family, to the surgeon I know will do a good job, and put my job in jeopardy? Or do I send them up the sausage tube to the abattoir, to the butcher that is also employed by the hospital I work for? No physician should ever be in that position. And I'm here to tell you it's inevitable. That dilemma will occur, and you just should never go to work for a hospital, and you'll never be in that position. So I've started and ended with that, and I guess I'll stop there and see if you guys have any questions.
Well, first of all, thank you so much. I'll continue to say I'm thankful for the work that you and your colleagues started to do and have continued to do, because it has truly made a difference in the world that we live in, and that a lot of people are fighting for. So I started with that and I'm going to continue with that. We have a couple of questions here on Zoom. How can free market discipline work in, and we've talked a few times about rural hospitals, and especially now with COVID, I think this is a great question. How can free market discipline work in a rural area where there is only one hospital provider?
It can work. It can work very well for a couple of reasons. One, it is working. Right now, there is this animal called direct primary care, and hopefully everyone listening is familiar. Direct primary care is particularly popular in rural areas where patients have historically had some difficulty with access to care. And the reason they have is that the payment rendered to the physicians in the rural area has been artificially set at a low price. So the physicians there either cannot stay in business at those low prices, or they choose to not see those patients because their only alternative is to go out of business. So rather than physicians avoid rural areas due to these price controls, basically, and remember, price controls cause shortages, instead of not locating in rural areas, we have physicians who have embraced the direct primary care model. And so they are now going back to rural areas. And that is really good for rural hospitals. The rural hospitals would much rather employ these doctors, but now the rural hospitals have to really deal with the demands of these independent physicians, because they will tell their patients if the patients are not getting good care, or that single hospital in that county is a price gouger, they will encourage their patients to drive over one county to a different county and patronize that facility. That was going on in the 1980s when I was a medical student. That was going on in the early 90s. You still see some of that, but I'm happy to say that activity of voting with your feet and just driving down the road a little ways to another rural hospital has pitted these rural hospitals against each other in a competitive way. And I think that we'll see that grow. And then when these rural hospitals realize they're in a competitive market, they'll provide better care at a lower price. That's not to minimize the plight of the rural hospitals, but understand the most difficulty that rural hospitals have is downstream and at the hand of the big city hospitals, which have victimized them by buying the physician practices in small towns and demanding that then their employees send all of their patients to the mothership in the big city. That then completely denies the rural hospital patient flow and gives the hospital the opportunity to buy that hospital very cheaply. So rural medicine has a lot of challenges, but there are also a lot of opportunities. The growth of DPC indirectly is the biggest opportunity that the rural hospitals have.
And if you're not, for people listening to this and watching this now, if you're not familiar with direct primary care, on our YouTube channel, we spoke to Dr. Kimberly Korba, who is just phenomenal. She's a DPC doctor in Pennsylvania. Next Thursday, we will be speaking to Dr. Chad Savage, both direct primary care doctors who are just doing phenomenal things. They're wonderful advocates also for direct primary care. Definitely check those out. Join us next Thursday as well. Just wonderful direct primary care doctors who are fantastic advocates across the country for what they're doing and how that builds into what Dr. Smith is talking about in the hospital setting, but also, in primary care. They're doing what a lot of physicians in primary care practices, private primary care practices, insurance-based primary care practices now had to backtrack and ask these DPC practices, how do we do this? How do we do telemedicine? How do we do this during COVID? So take a look at those videos and check those out. And I had to look this book up because I wasn't familiar with this, but one of our students said there's a book by Elizabeth Rosenthal called An American Sickness, How Healthcare Became Big Business and How You Can Take It Back. And it talks, she said, about what you're talking about. One of the things that this Elizabeth Rosenthal was mentioning was they don't care whether, and this is what our student says, they don't care whether the claims go up or down 20% as long as they get their piece. She said that this book, when she read it, it's a 2017 book. She said it really made her look at employee benefits and those kind of things that her father is a CEO, and when they're re-upping their insurance every year, how that is working for them. Do you get into that practice? Do you talk to business owners that are looking at re-upping their insurance and things like that? Is that something that you get into with benefits?
I rarely have that opportunity, and the reason is the brokers are very protective of that turf, and they do not want any outside voices talking to their clients, particularly because their clients will realize that they are not the actual client, that the Blue Cross, United, Cigna, Aetna is the actual client. There's a talk that David Contorno gave at the Free Market Medical Association 2 years ago. He is a recovering broker.
He's great.
Yeah, he's a great speaker, and the talk is worth watching. I think that Rosenthal's book overall did a service because it raised some awareness, but I think we have to be careful because as much bashing as the hospitals and insurance companies and big pharma, they deserve all the bashing that they get. But we have to keep in mind the primary culprit. The primary culprit is the federal government, because none of these schemes are possible without Uncle Sam. I tell people, remember that for all of the thieving awfulness in this industry, Uncle Sam is driving the getaway car. The federal government has created and auctioned off really the favors that had made all of the schemes possible. So I think that we raise awareness about all of the stink that's in the industry, and it's good to understand that, but we also have to understand that the only good government policy is the repeal of prior government policy, and the government just has got to continue to get out of the way.
Absolutely. Another question, could you address what about the uninsured middle class? I was waiting for that. The poor are covered by safety net programs. It is the barely middle class who face bills for health care that can be bankrupting and destroy the results of their prior frugality and financial planning.
Yeah, and the answer is what we're doing. I mean, the direct primary care doctors are charging somewhere between $70 and $90 a month for unlimited access to primary care. There are neurologists that are doing that. There are pediatricians that are doing that. There are rheumatologists that are doing that. So people that have repeat customer sort of physician practices have embraced that subscription model. When all of that was going on, there were many people who said, yeah, but what about really expensive stuff like surgery? Not knowing we had been posting prices online, since 2009 that are 1/10 of what the hospitals across town that are so-called not-for-profit charge for the same service. So markets do what markets do. This competition drives prices down and quality up. In every other industry, that is true. And it's true in the medical industry as well. So the answer to people who don't have a lot of money to pay for medical care is to make it less expensive. And then it's within reach of even more people. And I've never been more optimistic than I am now, because I'm actually watching that happen. Keep in mind, in 2009, I was adorned with a tinfoil hat for having been the first to put surgical prices online. Now, if you don't make your prices available for everyone to see, you pay fines. That is a 180. It's something that I never, ever would have dreamed was even possible. But now to not do what I did in 2009 is punishable by fines. So we're seeing a movement that is very powerful. These ideas have found the right time, and in many cases, the right people. We are all, myself included, standing on the shoulders of some giants that have preceded us. And the answer for everyone is for things to just cost less and for the quality to go up. And I think the only way for that to be achieved is for the market to be allowed to do its thing.
So we have a number of students, obviously, that are either in the process of applying for residencies. A lot of their residency applications have gone in. So picking their specialties, getting in that process. You're saying don't work in a hospital. Where do they get their experience? How does that come if that's not what they're going to do? Because that's the standard. You work in a hospital, you get your experience, and then you go someplace.
Yeah, and to be clear, my comment is don't work for a hospital. Mm-hmm. It's very important for physicians to work in hospitals, but to be salaried and be paid by a hospital is where I think we really have to scratch our heads and ask, what are the ethical and economic implications of that decision? All of the physicians I know that have gone to work for hospitals have regretted it and have tried to figure out a way to get out. There are all sorts of hooks and barbs on the hooks that make it difficult to wiggle off of that hook. So, yeah, I think when I made my decision about what to do, when I made my decision after, when finishing up my fellowship, where was I going to practice? I made a decision grid, and I tried to list all of the variables that were kind of going through my head and weight those variables, and then really look at it objectively. I decided that I wanted to work for myself so that I could work for patients. I decided that I just wanted to be free, that no one would have my interests or patients' interests more than me, and that if somebody else had their thumb on me, that probably was going to be leverage I would ultimately resent. So I resist leverage, and I have since I was a kid. And I do not like leverage. I do not like being pushed around. I like to acknowledge and identify what I believe are the things I ought to be doing, and then pursue those, and identify the obstacles in between and deal with those as they come along. I knew that I would have fewer opportunities if I were leveraged by people who were in the way. But that's who I am. And that may not be who everyone is. So choose your path, but do it with your eyes open and aware of the ethical and economic implications of that path. But not going to work for a hospital where a hospital is paying you is the admonition that I hope everyone receives.
Well, you definitely personify, our main focus at BRI is ensuring the doctor-patient relationship stays at the forefront of medicine. So what you're saying is what we personify, and, that path, whether it is like what you said, how you took it, or another path forward, is what we're hoping we can instill with that information, is what we can instill. With your path, starting your own practice, there is some business acumen that most medical schools don't give. In your experience, how can people get that? One of the biggest problems that a lot of medical students will say, without a doubt, is the lack of business acumen that they are receiving in medical school. What would be your response to that?
Yeah, I had no business acumen, I would argue, when I started my practice. I just knew that I did not want to be leveraged. I knew that if I wanted to take a left turn, that I wanted to be able to take a left turn. If I wanted to take a right turn, I didn't burn any bridges, and I would be able to do that. Mutually beneficial exchange is the golden rule. It's got all kinds of other names, but that is what has guided me in my decision making. And the more people I meet in business, I find ultimately that's where they fall back. It's never attempting to take advantage of someone in an exchange, not participating in an exchange, even one on the other side of which you're the primary beneficiary. That's not mutually beneficial. So just follow the golden rule, do the right thing, understand that the patient is sovereign. The buyer, the customer, is the one with the power. If they are not the ones with the power, then something is wrong. And there are, just some basic kind of economic things that I think people can read. Bastiat is a great place to start. Henry Hazlitt's Economics in One Lesson is a great place to start. If you're struggling with guilt issues but if I embrace radical individualism, what about everybody else in the whole world? Then just read Atlas Shrugged by Ayn Rand, and that'll get your head straight when it comes to how to think about individualism. And I don't agree with everything in her book and her Objectivist Creed, but that was very helpful to me whenever there were attempts to inflict guilt on me for pursuing my own path, even though I thought my path was the best path for the patients I took care of. And I would argue that looking back, I was right.
One of the things that I find for our students, I say that direct primary care, DPC, is a sexy thing to talk about. It's easy to talk about because people understand it. I am not a physician. But for me to talk about what free market medicine is, it's easy for me to explain to people. But the majority of our students are not going into primary care. So you're a free market anesthesiologist. To have other specialties that are doing what you're doing, it's helpful to have our students hear that there are people, that it's possible to practice the medicine that they want to practice, that they went into medical school to practice. Maybe not right away, but that it's possible to have that kind of practice someday, despite whatever specialty that they go into. Because I think that they hear so much about DPC once they get into this world. So that was something important to me. And I think it's very helpful for the students to hear that.
Yeah, and it's important for everyone listening to know that the surgeons that I work with all have blended practices. Mm-hmm. Most of them take money from insurance companies, but they also, when I call them and say, how much do you want for a cholecystectomy or a pacemaker placement or a lumbar fusion, they'll give me a price. And so by doing that, they are part of this free market movement. But there are even some of the DPC practices that are hybrid, that accept insurance. They're not all purists. I happen to be a purist. The Surgery Center of Oklahoma receives no money from insurance companies or the government. And that makes us a little bit of a unicorn, but we've been around for a long time. We have a great reputation and we benefit from that. But starting out, there is absolutely nothing wrong. In fact, it would be reckless to try to do, I think, what we're doing just right out of the gate, unless it's direct primary care, to your point. But a hybrid sort of practice with an idea toward purity, and it, I think, is very, very reasonable.
And I think that's really helpful. I think when DPC first started, again, there weren't people to help the new practices out, but now with so many other businesses that are helping these new practices out and understanding how the technology behind it, but also how to make those connections. I think, at least with DPC practices, that's available, and there are resources available to those new practices. I mean, we see young doctors coming out and starting practices right away. So I think it's an interesting dynamic as more other businesses are coming up to help those practices out. So it's interesting. We're right at about an hour now, and I don't want to keep you, considering you came to us from surgery. I am very thankful again for your time, but everything you've done for us, for BRI, for our students, for our movement. I love FMMA. I'm thankful for our relationship with FMMA and, everything that you've done. So congratulations on price transparency that I got to tell you about the CMS ruling today. What can you leave us with and our students with, besides not to work for a hospital?
Yeah, that's the main thing. Avoid leverage. Any debt that you acquire as medical students and as residents is leverage. And so to the extent that you can minimize that, you will be free and you'll enjoy the bounty that freedom and liberty gives you years from now. If you have a lot of debt, when you finish, I would encourage you to consider living like a resident or a medical student for a couple of years and just delay your gratification a little bit more. And then the rest of your life will be that much more leverage free, and you'll enjoy the bounty of the freedom and liberty that gives you. So identify it, acknowledge leverage, understand hospital employment is leverage, and you'll at least be looking through the correct lens, and that will help you identify paths going forward.
That's great. I have a daughter that's looking into medical school in 2 years, so I'm going to remember that. I want to thank you. Thank you to everyone that joined us today. We will have this recording up on our YouTube channel in just a couple of days. If you are interested in that, we do have Dr. Chad Savage next Thursday. And we have a full slate leading up until the rest of the new year, until New Year's, actually. So if you're interested, please join our newsletter on our website, and you will get all that information. So thank you, Dr. Keith Smith, for joining us today, and we will see everyone next time. Thank you so much.
Thank you.
I hope you enjoyed today's edition of the Benjamin Rush Institute's virtual events series. To learn more about our educational programs and events just like the virtual events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's virtual events series.